Imagine, a child stops breathing right in front of you. Panic sets in, but what if you could be the hero? Welcome to the ultimate 2026 American Heart Association PALS cheat sheet. This isn't just a summary. It's the most up-to-date PALS teaching video on the internet right now, packed with life-saving hacks, visuals, and tips. If you're a parent, nurse, health professional, or a doctor and want to master the PALS in 6 minutes, then watch this video to the end. Let's jump in, and please share this if it was helpful to you. Let's start with the basics. Normal vital signs by age. Newborns, heart rate 100 to 160 beats per minute, respirations 30 to 60, and systolic blood pressure 60 to 90. Infants under 1 year, similar heart rate, with blood pressure around 70 to 100. Kids 1 to 10 years, heart rate 70 to 120, breaths 20 to 30, and blood pressure roughly 70 plus, twice their age in years. Teens, basically adult-like, with heart rate 60 to 100. If you ever forget these in a crisis, use the Broslow tape. It's like a cheat code for dosing and gear based on length. Pro tip, check perfusion fast. Cap refill under 2 seconds, strong pulses, SpO2 over 94%. If not, you're in red alert mode. The PALS powerhouse, the systematic approach. Evaluate, identify, intervene. First, evaluate. If the child is unresponsive, start CPR right away. Then move to the primary assessment, ABCD. Airway assessment. Open it with a head tilt/chin lift or use a jaw thrust if there's suspected trauma. Breathing assessment. Assess the effort, provide oxygen if needed, and bag mask ventilate at 12 to 20 breaths per minute. Circulation assessment. Check the pulse in under 10 seconds, brachial for infants, carotid or femoral for older kids. If it's under 60 with signs of poor perfusion, start compressions immediately. Disability assessment. Use AVPU. Is the child alert, responsive to verbal, to pain, or unresponsive? Also check blood glucose and pupils. Exposure assessment. Do a full body scan while preventing hypothermia. Next, identify reversible causes using the H's and T's mnemonic. Things like hypoxia, hypovolemia, toxins, and more. Finally, intervene smartly. This framework turns total chaos into control. Master it, and you'll feel unstoppable in a real emergency. High-quality CPR done right can save a life and protect the brain. For the rate, make sure is 100 to 120 compressions per minute. Think of the beat from the song Stayin' Alive. For depth, make sure is about 1/3 of the chest, roughly 1.5 inches for infants, 2 inches for kids. Allow full chest recoil and keep interruptions under 10 seconds. Single rescuer, 30 compressions to 2 breaths. With a team, 15 compressions to 2 breaths for infants. For older kids, continuous compressions with asynchronous ventilations. Key 2026 update. For patients with a durable LVAD, adults and children, prioritize chest compressions if perfusion is poor, even if a pulse is present, while troubleshooting the device. Defibrillate early. Use pediatric pads for kids under 8 years. First shock at 2 to 4 joule per kilogram. If you are seeing end-tidal carbon dioxide over 10 millimeters of mercury during CPR, you're doing it right. It's a strong predictor of survival. For cardiac arrest, no pulse, or heart rate under 60 with signs of poor perfusion, start CPR immediately. Check the rhythm every 2 minutes. Shockable rhythm, VF or pulseless VT. Perform 2 minutes of CPR, deliver a shock at 2 to 4 joule per kilogram. Resume CPR immediately and give epinephrine, 0.01 milligram per kilogram, via intravenous or intraosseous route every 3 to 5 minutes. If it persists, consider amiodarone 5 mg per kilogram or lidocaine. For non-shockable, asystole or PEA, high-quality CPR plus epinephrine every 3 to 5 minutes, and aggressively hunt for reversible causes. Once you achieve return of spontaneous circulation, jump straight to post-arrest care. Start with 100% oxygen initially, then titrate. Target EtCO2 of 35 to 45 millimeters of mercury. Maintain blood pressure above the 5th percentile for age, and keep glucose 70 to 180 milligrams per deciliters. Key 2026 update. Stronger emphasis on bundled post-arrest care to optimize neurologic outcomes. Pro tip, always debrief after every code. Studies show it improves team performance and future outcomes dramatically. For bradycardia with poor perfusion, always start with the ABCs, then give epinephrine 0.01 milligrams per kilogram intravenous or intraosseous. If you suspect increased vagal tone or a primary AV block, try atropine 0.02 milligrams per kilogram, minimum dose of 0.1 milligrams. If there's no response, consider transcutaneous pacing or additional fluids and get expert help fast. Now, tachycardia with poor perfusion. First, assess the QRS duration. Is it narrow or wide? If it's a narrow QRS, that's likely SVT. Try vagal maneuvers first. Use an ice bag to the face for infants, or have older kids bear down with Valsalva. If that doesn't work, give adenosine 0.1 milligrams per kilogram rapid push. Second dose can go to 0.2 milligrams per kilogram. Still unstable? Start synchronized cardioversion at 0.5 to 1 joule per kilogram, escalating to 2 joule per kilogram if needed. Is it YQRS? Treat it as ventricular tachycardia. Start synchronized cardioversion or give amiodarone 5 milligrams per kilogram intravenous over 20 to 60 minutes. Every time you see tachycardia, ask yourself, QRS wide or narrow? It's an absolute game changer for choosing the right path. Shock hits hard in kids, so recognize and treat it fast. For hypovolemic shock, start with a 10 to 20 milliliters per kilogram isotonic crystalloid bolus. Reassess carefully and repeat as needed, watching for overload. For distributive or septic, same initial fluids, plus early broad-spectrum antibiotics. If fluid refractory, add vasopressors like an epinephrine infusion and consider stress dose corticosteroids. For cardiogenic, use smaller, cautious boluses, 5 to 10 milliliters per kilogram, or none at all. Focus on inotropes like dobutamine or epinephrine and avoid volume overload. For obstructive, treat the underlying cause urgently, like pericardiocentesis for tamponade or needle decompression for tension pneumothorax. Key meds to remember: epinephrine 0.01 milligrams per kilogram in arrest, adenosine 0.1 milligrams per kilogram first dose, 0.2 milligrams per kilogram second, amiodarone 5 milligrams per kilogram for refractory VD/VF, magnesium 25 to 50 milligrams per kilogram for torsades to points. Mnemonic to remember: AP for the crash, adeno for the tachy flash. For respiratory distress or failure, let's break it down quickly. For upper airway issues like croup, nebulized racemic epinephrine 0.5 milliliters of 2.25% solution plus dexamethasone 0.6 milligrams per kilogram. For lower airway issues such as severe asthma, use continuous or frequent albuterol nebs and add 4 magnesium sulfate 25 to 50 milligrams per kilogram if it's really bad. For respiratory failure issue, try non-invasive ventilation first, like CPAP or BiPAP. If that fails, then prepare to intubate. For suspected opioid overdose, give naloxone 0.1 milligrams per kilogram via intravenous or intraosseous route, up to 2 milligrams max per dose, and repeat as needed while supporting ventilations. Remember, team dynamics are what win real codes. The leader must assign clear roles: compressor, airway manager, monitor/defibrillator, meds, and recorder. Use closed-loop communication, such as, "I need epinephrine," confirm you've got it, and always debrief afterward. It dramatically improves future saves. Boom! You've just mastered the gold standard PALS summary based on the latest 2026 guidelines. Practice these skills regularly, get officially certified through the American Heart Association, and always remember, high-quality care starts with you. What's your biggest takeaway from this? Drop it in the comments below. Please hit that like button, share this video, and subscribe to my channel for more life-saving and educational content like this. 5 together, we're helping save kids' lives. Stay heroic. I'm Nurse Frank, your friendly acute care RN.